Welcome to Medical Myths, Legends, and Fairy Tales. I'm your host, Dr. Alan Christensen. Look, you know that between the latest online fads and the crazy media headlines, it's easier than ever to get confused about your health. And you and I just want to feel better and live longer. We want to know what works. And we can't wait for further studies. We need to make decisions today based on the best evidence we've got. Well, that's exactly what this show is here for. So let's get to it.
Hi there, this is Dr. Linda Kashaba from Integrative Health. Would you like some help with your thyroid? We would absolutely love to help you out. And guess what? We can even do remote care. Please call us today at 480-657-0003 to set up your first appointment. If you mention code podcast20, you will get 20% off from your first visit. That phone number again is 480-657-0003, and the code is podcast20. Can't wait to meet you.
Hey, Dr. C here. So are grains harmful for those who do not have celiac disease? This is one in a three-part interview series in this topic, and in this one I'll talk to my friend Dr. Peter Osborne. Dr. Osborne is the author of the book No Grain, No Pain. He's the founder of the Gluten-Free Society, and he's been called the Gluten-Free Warrior. As you might guess from some of those, he's got strong views about grains, and he's done a lot of work helping people with autoimmune and degenerative diseases for many years. We talk about his experiences, we talk about a few citations he found, and how he's come to the conclusions that he has. And he's made a big difference in a lot of people's lives, so I'm glad to have had some time to share with Dr. Peter Osborne. Hope you enjoyed as well. Hey, Dr. C here with you again. Super happy to be with another episode of Medical Myths, Legends, and Fairy Tales. And Dr. Peter Osborne is with us here now. Hey, Peter, welcome aboard.
Thanks for having me, Alan. It's great to be here.
Hey, this is really cool. You're someone I respect and have known for quite a while. You know, there's just a lot of contention about the role of grains and human health overall. And I think no one would debate that refined grains, sugar-sweetened products made from them, eaten in excess, are just not good for anyone. And I think no one would debate that a certain subset of the population has celiac, wheat allergy, non-gluten sensitivity, and they've got some special reactions as well. But I'd love to just start out with opening your thoughts about grains and human health overall, and then we'll start to talk about your references after that. So yeah, what are your thoughts?
Well, I think there are two camps in the medical literature on grain. A lot of the evidence shows that grains and the fiber they contain have a clear benefit, but the vast majority of the research done on whole grain and its impact on the reduction of chronic degenerative diseases like heart disease and cancer and diabetes, most of these studies are observational and not actually double-blind randomized placebo-controlled trials where they have taken grain-free diets versus whole grain-containing diets, as well as controlling for the other variables of healthy choices that people might make. So, for example, like smoking and alcohol, exercise, socioeconomic status, like all of these other factors matter tremendously. And that's why I think there's two sides of evidence that show, and some studies show the benefit and some studies show the detriment. I tend to fall on the side of the camp of avoiding grain or not having grain in the diet if there is a genetic predisposition toward the potential to react to it. And that goes back to clinical practice. As you know, there's research, and then there's what actually happens kind of in an N equals 1 setting.
So genetic predisposition being one factor you take into account, you're saying? And
yeah, absolutely. The biggest factors that I look at, clinically when I'm asking somebody to change their diet more toward a grain-free lifestyle, one of them is the presence of autoimmune disease. And that relates back to what we know as far as the research is concerned around causation of autoimmunity. Arguably, the number one medical condition that is autoimmune that we are absolutely certain about causation is celiac disease. And as a model for autoimmune disease, I feel like, and I really wish the researchers would get more on board with this, and some of them have, But we don't have enough research where we take the vast array, and there are 100 different forms plus of autoimmune disease, but where we take these different forms of autoimmune disease, doing dietary intervention trials of grain-free diets or gluten-free diets to see the impact on autoimmunity, not just in celiac, but in other various forms of autoimmunity. I mean, there have been some really good studies that have been done that show going gluten-free actually can impact people with autoimmune cerebellar ataxia. There have been research studies linking psoriatic arthritis and rheumatoid arthritis and multiple sclerosis and a handful of other autoimmune diseases to improvements with a gluten-free diet. But it's just not an area that gets a ton of research or, in my opinion, enough attention.
So what are your thoughts about some of the larger studies that show reduced gluten, reduced grain diets lead to worse health outcomes? And you talked about certain variables, but there was a big one showing about the increased rate of cardiovascular death in those who electively went gluten-free, and they correlated that with decreased whole grain. You're probably familiar with that and probably have some perspective on that, or?
Yeah, I don't agree with those studies in this concept of because somebody goes on a gluten-free diet, we have to look at how their gluten-free diet was imparted onto. So what I mean by that is you take the average person who goes to a major hospital, gets a diagnosis of celiac disease, because that's typically who's going gluten-free. Not to say that there aren't a number of other people without celiac disease that also don't go gluten-free. I mean, there's a trend in that direction for chronic disease. But I'm talking about the people that, get their diagnosis of celiac disease. And one of the things that happens on the day of diagnosis in many of these major hospitals is they get a gift basket that's full of what are being called gluten-free goodies or gluten-free food-based products that are highly, highly, highly refined and have other problems with them. And so I think for anyone, if we took fiber out of the diet, and whether it was a whole grain fiber or whether it was fiber in general, and we replaced it with highly processed, highly homogenized foods, I think we would see an increased risk for most forms of inflammatory disease. So, although I'm familiar with the study you're talking about, I don't think that they controlled well enough for the types of foods that these individuals were choosing, because again, most people go to that gluten-free food aisle where they're buying, highly processed rice, highly processed corn products, not even to mention some of the genetic manipulation, the potential for pesticides or pesticide contamination in these products. And they're turning these products into staple foods. So these staple foods containing the vast majority of calories that the person is eating. And of course, anytime we see a society choose its staple forms from highly processed food, we see an increase in chronic degenerative disease. So I don't think we can blame the gluten-free diet. I think we have to look and analyze at how the gluten-free diet was implemented and in what strategy, what intelligence factors were being put into place. Because if in my practice, 20 years now, I see people staying on grain-free diets for decades, doing fantastically well when we have monitoring and follow up, on their inflammatory markers and on their disease risk markers. They're passing with flying colors, even though they're not consuming whole grains. They're consuming fibers in other ways, but they're also not consuming the quantity of processed gluten-free foods that so many people with celiac disease tend to rely on.
So for some people, the quality of the diet may be a bigger factor than their gluten intake or their grain intake. Is that what you're concluding, or?
It is, and although I don't have published research on this yet, I'm not quite yet retired. And when I retire, I'm going to be crunching a lot of numbers, because I've been collecting data now for a couple of decades on nutritional status of people long term on grain-free diets. And what I find is that these individuals on grain-free diets, again, who are autoimmune in nature and genetically screened for predisposition, that are going on grain-free diets in an appropriate setting, these individuals have less nutritional deficit and really have a much greater nutritional report card, so to speak, when we look at objective markers, both in the blood as well as inside the cells.
Yeah, that'd be great to crunch some data, compare some cohort studies, and look at some analysis from that. That would be a helpful thing for the greater body of literature. So autoimmunity. So just general recommendations. Would you argue that most anyone would improve their health by, still staying on high quality foods but excluding grains, or would you argue that it's more so certain subpopulations, or what are your thoughts that way?
I can only share what my experiences are, and of course my thoughts are going to be formed from my experiences. I've not yet met a case of autoimmune disease in an individual who didn't have a vast improvement when going grain-free. That's my personal experience in seeing more than 5,000 patients over the last 18, 19 years. So that's just my personal experience. So I think I probably have a biased opinion on it because it's just been my experience, and I've seen people's lives go from, borderline hospital to all the way from being, terminal diagnoses to thriving. And so, I tend to lean on the side of, if you've got an autoimmune disease, you really, really want to analyze whether or not going gluten, or really, in my opinion, grain-free. I would just say gluten-free, as defined by the FDA and the government here, is wheat, barley, and rye-free. But I have found that corn and rice and oat and some of the other grains and grain substitutes have shown in many of my patients to be very detrimental to them when they're trying to recover from autoimmunity.
So any opinions on populations apart from those with autoimmunity, or?
I think we'd have to see that. I mean, because there certainly are other cultures where we can see grain as being part of that culture, and that culture not being entrenched in massive quantities of autoimmune disease. I think if we really look at, I'm a student of history, so I really like to look at what's happened with autoimmunity in the United States since the early 1940s, and we're seeing this exponential growth. And so when we start asking the question, why is this exponential growth there? Is the food that different? Is the environment that different? Are people's behaviors that different than they were, let's say, 50 years prior? And I think we could certainly point out there are a number of differences. Some of those differences being the genetic manipulation, the genetic hybridization of crops. Some of those differences being the way that things are farmed. Certainly, today's current farming practices erode the soil in a very dramatic way, reducing the micronutrient status of the food overall, not even just grains, but most foods. We've got 30,000 approved chemical compounds that are in our environment today that we didn't have 50 plus years ago. 3,000 of those chemicals are approved as generally recognized as safe chemical additives in our food. I think we have, if you look at the vaccine schedule, I know this is not a vaccine debate, but if you look at the vaccine schedule, starting in 1986, the liability laws were basically manufacturers of vaccines were no longer being held liable for damage that was created as a result of vaccine injury. And the schedule went from 7 doses to, I think, somewhere around 43 doses. So there's definitely a lot more adjuvants from vaccines that are being introduced into very young children. And of course, if we're talking about autoimmune disease, this term was not coined by myself. It was actually Dr. Yehuda Schoenfeld, one of the world's leading researchers in autoimmunity, coined the term ASIA, autoimmune inflammatory syndrome induced by adjuvants, indicating that adjuvants are also a trigger in autoimmune disease. So I think we really have to look at those factors. We also have to look at lifestyle factors in terms of people's activity. Today's workforce, today's student force, it's more sedentary than it's ever been. And so I think that plays a very, very big role in weakening a person's overall health status. And so when you look at all of these variables together, it's really hard to say, no, it's just grain and the increase in grain in the diet. We have to look at all of these things together in the individual as they stand in front of you and help them make some better decisions about how they can live their life to try to prevent and avoid autoimmunity. And that's kind of where I stand, because any study, and you know this too, Alan, any study, large group studies, a lot of them are observational because you can't control for the variables and the other factors. And even when you try to statistically control for them, you still miss out on a lot of data that could impact the outcome of that research study. And so I think ultimately, the old adage N equals 1 is the most important thing that we could take into consideration, meaning the patient's outcome based on the changes that are made are right if the patient gets better, regardless of what any study might ever have said.
Yeah, and I think we still have the same issue to contend with as far as multiple factors of clinical care. Oftentimes we think about how things are done in research, where they do their best to isolate a certain variable. And clinical practice, when you and I have a patient before us, we just want to do whatever we can to help them get better. And knowing well that we're not doing a great job controlling variables at all, oftentimes quite the opposite.
Yeah, and then there's also, I would say too, there's also, practitioner confidence.
Yeah.
Some patients borrow the confidence of the practitioner, and that helps them get better psychologically. And when they start believing that what they're being told is right, and as they're moving forward, then they get better because that's what they believe. And the power of the mind is extremely important in all of this. And I think that's very hard to control that as a variable.
That's such a huge factor. I couldn't agree more. And then another factor too is that, and I've thought this through a lot of all the various things that can predict someone's health improving. I think you just nailed one of them. Someone's general mental state, their level of resilience, their confidence, their stress response, however you want to put that, HPA axis. And I think another one is often just where the body is in terms of overall fuel balance. Is there too much fuel relative to need or too little? And so I think also in a lot of ways that any way the diet changes that puts someone back away from a state of fuel excess often ends up being radically helpful.
Yeah, I couldn't agree more. And on that same note, I would just comment that what we've seen since Ansel Keys published his, I'll call it limited data, because it was, I'm sure you're aware of the original cholesterol research in the 21 country study that actually got published as a 7-country study for the promotion of a low fat diet. But since that time, the government, at least in the US and the American Heart Association, has adopted this policy around a low fat diet, particularly, demonizing saturated fat. And what I think it's led to in our society, it's led to a carbohydrate toxicity. And so I think some people that go grain-free find improvements in the fact that they're no longer consuming just the vast majority of their staple calories from carbohydrates. And so they're bringing their body back around the balance. I think we're seeing the same trend with ketogenic diets. Although I think there are certain clinical conditions that absolutely benefit from ketogenic diets, like epileptic seizure disorders and other neurological disease and some cancers. Overall, I think what we see with some of these diet trends and changes that have happened over the last 20 years in functional medicine is really just vastly deviated from a carbohydrate toxicity that's been thrust upon us from this data that it was so limited at its time, but was so widely and universally accepted as truth.
And yeah, along those lines, it's that drop in fuel. The change in total fuel can be a big difference in just tons of ways. We'll be right back after a word from Integrative Health.
We hope you're enjoying this episode of Medical Myths, Legends, and Fairy Tales. This is Dr. Raquel Espinal at Integrative Healthcare. So often we hear from our new patients that their primary care physician has told them that their thyroid and hormone levels are fine and they should not worry. Yet the patients still have symptoms of severe fatigue, thinning hair, and weight issues. Unfortunately, this is too common with thyroid care. The good news is we can help, and there is hope. The doctors at Integrative Health, including myself, specialize in naturally treating your thyroid, your hormone, and adrenal issues. We would love to get you started on the path to ideal health. From the comfort of your own home, you can get treatment with one of the doctors at Integrative Health via telemedicine. Go to integrativehealthcare.com to become a new patient today. Use the code PODCAST20 for 20% off your new patient visit. Again, that is integrativehealthcare.com, and use the code PODCAST20, all one word. Get back to the road to thriving. We look forward to seeing you.
And now, back for more medical myths, legends, and fairy tales. You sent over some studies ahead of time. Thank you so much for that. That was super helpful. And I went through all of those. They were mostly on non-celiac gluten sensitivity. Is that it's a really important topic, and that's one certainly that we could focus a bit on. What are your thoughts about just the prevalence of that and diagnostic pitfalls about it, and how would someone be aware if they would have that or not? And let's go down that line a little ways if you don't mind.
So in my experience, I'll give you kind of my two thoughts. One on what is in the literature and the research, and the other is just based on, again, my clinical experience. Because I've changed in my clinic, I've changed over the years as I've gained more experience and seen what has worked directly working one-on-one with patients. But originally, I had a young girl come to see me. Her mom brought her in. She was 9 years old, and she had a terminal diagnosis with 6 months to live. And her diagnosis was juvenile rheumatoid arthritis. And so she had been in and out of the hospital so frequently that they had an IV stent embedded in her arm to put her on pain medications from the severity of inflammation in the bouts of flares that she would have. And in her case, what we found, Alan, was that she was genetically predisposed to gluten sensitivity. She had the right set of markers, but nobody had ever talked to her about diet change. Nobody had ever talked to her mom about diet change. And when we took her gluten-free, she improved dramatically. But when we took her grain-free, she recovered fully without the need for any more medications. And within about a year's time, she was in complete remission after having a terminal diagnosis and only being given 6 months to live. And that was kind of the antecedent, if you will, of kind of why I changed and started moving more in this direction. Because in her case, juvenile rheumatoid arthritis is kind of a rare thing. It's a form of rheumatological arthritis that affects children. And, you know, it's an autoimmune disease. And part of why we investigated gluten, part of why I investigated gluten is because of the linkage between gluten and autoimmune disease as it relates to celiac disease. But there's a growing body of evidence in the medical literature that shows that people can react to gluten in more ways than one. In essence, non-celiac gluten sensitivity is kind of the wheelhouse of the inclusiveness of all the other ways someone might react to gluten that doesn't include villus atrophy when they have a intestinal biopsy done to identify, you know, that flattening of the villi. So finding that the diet change could save somebody with an autoimmune condition that was non-celiac as my first kind of clinical experience in dealing with autoimmune disease led me more and more to let's look at genetic markers and let's look at other indicators in the bloodstream of other food intolerances or food allergens and sensitivities, and let's really hone in on food as a potential trigger for autoimmune disease. So I spent a number of years in clinic, you know, really focusing on diet change and supporting nutritional deficit, because many of these people were coming to me and they were devoid of the right nutrients. So even if they had not, well, let me reframe that. Even if they had been eating gluten or not been eating gluten, rather, they still had nutritional deficiency that was kind of leading to a delay or a lack of progress in their condition. So like, as an example, it's pretty common in my experience to see people with gluten-induced neurological problems that even after they go gluten-free, not to heal or recover until they get their vitamin levels corrected. And the most common deficiency I've seen in that regard is vitamin B12 deficiency. And so measuring those two things just again in clinic led me to the more and more I did it, the more and more I could confirm that when we found those things out, we could get them to recover when all other doctors and all other specialties and all other experts had not been able to get them much symptomatic relief, even with medication.
So your thoughts about the prevalence or diagnostic process for non-celiac gluten sensitivity?
Well, I don't want to claim to know what the prevalence is, because the research shows that if you're talking about celiac disease, 1 in 133, and some studies show as many as 1%. But if we're talking about non-celiac gluten sensitivity, I've seen some research say 3%, and I've seen some say as high as 30%. But I don't think anybody really truly knows, because I think there are too many variables that can trigger it. So like, whereas genetic susceptibility is one of those triggers, right? And so, you know, some people will say, well, genes don't dictate the disease. You know, the behaviors around the genetics are what contribute to it. So if we look at some of the factors that, let's just say somebody has a genetic predisposition to gluten sensitivity, well, what are some of the factors that are going to activate that and turn that on and accelerate it in a very big way? There are a lot of them. One of them is pesticide exposure, which we have more of in our population. Another is plastic exposure. Plastic exposure is actually, phthalate exposure has been shown to cause intestinal permeability and accelerate gluten sensitivity. Antibiotics have been shown to accelerate it. Certain blood pressure medications, a class of medications called ARBs, angiotensin receptor blockers, have been shown to actually cause celiac disease, even in the absence of the genetic predisposition for celiac disease. So there are a number of environmental factors and triggers. Certain components and adjuvants in vaccines have been shown to be part of this trigger. If we really kind of summarize what the triggers are, very simply put, without including stress as one of those triggers, vitamin and mineral deficiencies, infections, chemical exposures, and chemicals and nutritional deficit and infection are four major wheelhouse triggering points for autoimmune disease. And so I've gone more and more in that direction to looking at all four of those families of triggers by running appropriate objective laboratory testing to help me isolate how a person needs to change their diet and their lifestyle around their genes so that we can get a favorable phenotypic expression.
I guess the point that I'm circling around is if someone is not known to have celiac disease, how would they go about knowing if this were relevant for them? If let's say they weren't struggling with autoimmunity, they didn't have other compelling reasons, how would they know if they had a gluten issue otherwise?
My favorite way to really ascertain it is looking at genetic markers, looking at the Hla Dq gene patterns from both the alpha-1 and the beta-1 gene of Hla Dq, which is on chromosome 6. And what I have seen in my trend is, and I have other colleagues that are deep into the research around gluten sensitivity, particularly non-celiac gluten sensitivity, is that the big markers that we see predispose people to reactivity to gluten are the traditional celiac markers that some doctors already measure, like the Hla Dq2 or Hla Dq8 positive associations. But there are what are called non-celiac genetic markers as well. When I say non-celiac, I mean non-celiac gluten sensitivity genetic markers, and those are Hla Dq1 and Hla Dq3 genotypes. So when looking at those markers and finding positivity within those markers, it's generally my advice in somebody in a clinical setting with autoimmune disease that they need to avoid gluten. And I've not yet seen a single study or a single case where that didn't show profound improvement in a person's overall health as it related to their autoimmune antibody numbers. So like if they were coming in, for example, and let's say they had Hashimoto's and their thyroid peroxidase antibodies were up over 1,000. Well, just a simple change in diet, going gluten-free, really truly grain-free, we can see the antibodies drop tenfold in as little as 6 months. And that's a very, very common thread that we see. We see the same thing with rheumatoid factor. We see the same thing I've seen it with other antibodies related to a number of different autoimmune diseases. If a person really wanted to know, I would advise genetic testing. But let's just take the opposite of that. Let's take a person, like you said, that doesn't have autoimmune disease, that appears, in all intents and purposes, appears to be perfectly healthy, and they're eating gluten. Should they go get genetically tested and start avoiding gluten? Not necessarily. If they really want to dive into it a little bit deeper to discern whether or not they have an autoimmune disease that has the potential to blossom, then there are a couple different labs that run kind of an array of autoimmune markers to a number of different tissues, like the liver and the brain and the skin and the bone, etc. And so that can be done. And some researchers, I think it was Arbuckle at the VA hospital, who found that they had this really unique situation, Alan, where they had access to blood work that was decades old. And so what this researcher did is went back and analyzed this blood work that was like 30 plus years old. But because it was the VA hospital, they could look at this old blood work from military personnel, and they were able to call them up like 30 years later, but it wasn't 30 years later because they had the blood work that was 30 years old. So they looked at the blood work in today's time, but then they were able to call these people up and say, hey, 30 years ago, you had positive markers for lupus. Did you develop lupus? And the predictability of those early onset autoimmune antibodies was like somewhere in the neighborhood, and depending on the disease, it was 90+% predictable, meaning if they had high levels of antibodies earlier on in life, then a couple of decades later, they would actually go on to develop the autoimmune disease. And that field of research now is being called predictive autoimmunity. So if somebody really wants to be ultra preventative and kind of figure that out, they can certainly ask their doc to run an array of different antibody tests for various types of autoimmune disease and see if those things are showing up, even though they may be symptomatic, because what the research shows is that knowing that whether those antibodies are present can allow you to make diet and lifestyle changes today that might basically head that disease off at the pass, so to speak.
That's awesome. Yeah, if you can stumble across that, I'd love that reference. Did they mention the sensitivity by any chance about like just those who were positive for antibodies but did not go on to develop disease? Or
I don't recall that particular statistic. I'll have to go back and read it. It's been a few years since I've read the study, and when I pull it up, I'll send it over.
Cool. Yeah, you sent over several other good ones. I didn't know if you wanted to discuss those in any more detail. You know, one thing that did fascinate me is I hear many struggle about symptom changes in terms of subjectively doing better, and then debates that researchers have about accuracy of symptom changes for determining non-celiac gluten sensitivity. You know, one of the papers that you meant referenced the Salerno experts criteria as a real gold standard. And in that, they talked about the idea of having to do a blinded challenge test, at least a single blind challenge test where the participant is not aware of their gluten consumption, and then looking at their symptoms. And they argued that the self-perceived gluten-related symptoms are rarely indicative of the presence of non-celiac gluten sensitivity. That was a quote from one of those. So what are your thoughts about just the pitfalls of making a dietary change and judging it in ways that may not be accurate relative to what the change was?
I think because food is a slow poison and usually not a fast poison, it's really hard to judge it symptomatically based on the way they were reporting in that study. I get some people who are so sensitive to gluten that trace amounts, send them to the hospital. I get others who maybe not even really truly gluten sensitive, but highly anaphylactic, allergic to wheat. And so again, the time from the exposure to the food to the actual symptomatic outcome, who gets to judge what that is? Because even if we just look at the fundamental basics of the immune system itself, an IgE response or an acute anaphylactic response, the window of reactivity is anywhere from 0 minutes, right away, immediately, to 3 hours. So there's a 3-hour window there. And what's the cutoff that they're using in research studies, number one? But two, with acute anaphylaxis, it's a lot more obvious and it's a lot easier to observe those types of symptomatic changes. But there's also something called subacute changes. And Doris Rapp, who was a pediatrician who really one of the leading experts, she's passed on, but she wrote a great book. And she talked about what she used in her clinic as trying to identify whether a person had a non-anaphylactic subacute allergic response to particular foods. And so some of the things that she found were increases in pulse. So she would actually measure or have people's pulses measured. And what she found and concluded is that with subacute reactivity, sometimes the only symptom to change immediately within that first block of time is your pulse goes up, because the adrenaline output, because of the danger of the subacute response, created a physiological adrenaline change. And so, if they're not measuring that, they may miss somebody's symptoms. But then there's also the delayed hypersensitivity pathways, the other antibody pathways, the IgG, the IgA, the IgM, the immune complex, and then the T cell directly, the T cell response. And there's a window of, 3 weeks before symptoms could set in, because that pathway takes a little bit longer to kind of gear up. And some believe that when I said earlier that food is a slow poison, some believe that it's not one exposure, like it's not like the 20 parts, per million of gluten exposure that we know is enough to create an inflammatory response in a celiac, but it's an accumulated level of exposure over time that leads to subsequent events. Think of it as like, okay, we got enough exposure, then the body couldn't keep fighting, couldn't keep controlling the inflammation. And so as that inflammation got out of control and did damage, and that damage became symptomatic, like there's a time frame from exposure to actual damage. And that time frame doesn't always fit within, person's direct observation within a few hours of that meal. And I think that's a big part of why that criteria from the Salerno experts is not really all that accurate or adequate. But then you have other things too. I mean, there certainly are other things that some researchers are trying to identify. Some people say, well, it's not so much gluten sensitivity, it's FODMAPs, which are fermentable alcohols, basically fermentable alcohols and fermentable sugars. And so some people are reacting to the FODMAPs that are high also in grain-based foods. And some would also argue that it's the glyphosate, because of the way our commercial crops are sprayed today. And so it's not really gluten, but it's the glyphosate. And some are arguing that it's the genetic hybridization of our wheat crops that are really contributing to a big part of this. And some are arguing that it's the genetic manipulation itself. And some are arguing that it's the mold toxicity of grains as a whole. And many people are mold allergic. About 5% of the US is mold allergic. So there's all these other variables that, in my opinion, to really tease out the truest answer in all of this is to go in and dive into all these different variables and see what we really have. Is it gluten sensitivity? Is it grain reactivity? Do we need to change the terminology and the definition? And then from that terminology and definitional change, do we need to kind of create subcomponents underneath it so that we can get more specific about whether or not a person is reacting to the gluten or reacting to some other substrate or substance?
And if I'm hearing correctly, you're making the determination less so per things like the Salerno criteria or factors like that, but more so just, a lot of clinical observation and patient outcomes. Would that be fair?
It would be, and it would also be present in a lot of the literature. There's a lot of literature on mold toxicity of grain, particularly corn and rice and wheat, as being contaminated with molds like Aspergillus, and also being contaminated with mycotoxins produced by Aspergillus, whereas a mold is an actual life form. A mycotoxin itself is not a living structure. It's more like a metabolite that mold produces that can be poisonous to humans. And although our food supply is somewhat controlled of mycotoxins, it's an accumulation effect, meaning some people accumulate it more readily than others. Some people detoxify it less effectively than others, and some are more susceptible to it than others. There's research on mold. There's research on mold toxins. Actually, when I wrote No Grain, No Pain a couple of years ago, there were 323 references I put in large part, these are some of the factors that I'm talking about. It's not just gluten. I think the conversation is so much deeper than gluten sensitivity or even non-gluten or non-celiac gluten sensitivity. I think really grain and some of the components of grain, which is kind of the hallmark of this conversation, right? Which is, are whole grains good for us or are they not good for us? And going back to the how the research splits, is many would say that whole grains are great for you. But again, most of the studies are observational and they're not double-blind controlled trials where you actually compare a grain-free diet versus a non-grain-free diet, look at the other variable factors and control for them and see what the outcome actually is in terms of disease elimination or disease risk reduction.
And I guess a couple of thoughts, one of which is, if we're seeing that there's certain variables that are relevant, like molds or pesticides or hybridization, it can become hard to tease apart one part of the diet from others when these are elements that could apply to other parts of the diet. Yeah.
Oh, absolutely. I think that's the biggest challenge that we face to get true clarity is, how do you control for all that? And then, so because some people will say, well, I'm not gluten sensitive, so I'm going to eat the grain, and they're reacting to the mold, but the reaction is not an acute anaphylactic response, but the person ends up with, an immune suppression that invariably can lead to cancer. And that's what mycotoxins can do. They're known carcinogens. So, it's a slow poison. And that's another factor that makes it very hard to study. How do you study slow poison over time? You do it with observational studies. And you do it from observational studies. You try to dial in and get a little bit more meticulous and specific. But a lot of this food-based research and plant-based research isn't funded very well. A lot of our research grants and research money go more to the funding of drug intervention studies versus, let's say, the studying of the compounds that are found in our foods.
So there's times in which observational studies can be helpful. And I would argue too that clinical practice is akin to a case series. We're seeing people over periods of time. If we do a good job, like sounds like you've done, documenting outcomes, we're collecting data and we're putting together numbers from that. And we always know that it's never perfect because, like you said, there can be other variables that are present. But yeah, sometimes that's the best we can do is base things off of observation.
Yeah, I mean, it's definitely a great place to start. I think observation has changed the world to a much better place. I mean, the observation, early on in the 1800s, that water could spread the contaminant that led to a number of different infectious diseases, led to water treatment, right? And that arguably is one of the greatest advances in human civilization to reduce infectious disease deaths.
Yeah. So, boy, those are the main points I'd had queued up. Are there things that you had top of mind relative to this that we didn't get to, or points you wanted to cover or share with the audience? Or
yeah, I think going back to non-celiac gluten sensitivity, and I just want to point this out to the audience because many of you may struggle with some form of autoimmune disease or some other form of nefarious chronic degenerative disease, and maybe you've been to the doctor and the doctor says that the disease is, we don't know what causes it, and that you have bad genes, or that it's just your family history and you just have to learn to live with it, or you're just getting older. Like, these are a lot of the excuses that I hear in people that come to see me in my clinic. And not very many people are aware that non-celiac gluten sensitivity is an array or a battery of a number of different diseases that have actually been shown in research to be validated, meaning that gluten can actually cause these things. And when I say gluten, not like what we were talking about before, where we're talking about molds and mycotoxins and the other things found in grain. Like, gluten can actually cause cerebellar ataxia, which is a disease that causes severe imbalance and puts many people in wheelchairs. So, those of you out there that may be struggling with cerebellar ataxia, that may be struggling with a neuropathy and you don't know why, the numbness, the tingling, the radiating pain in the arms or the extremities of the legs, those have been linked to non-celiac gluten sensitivity. So if you're struggling with those types of conditions, if you're struggling with autoimmune hepatitis or unexplainable infertility, these have also been linked to non-celiac gluten sensitivity. If you're struggling with lupus or psoriatic arthritis or rheumatoid arthritis or multiple sclerosis, you could have a form of non-celiac gluten sensitivity, and that could be one of your major triggers. So I just want to make that clear to anyone listening in the audience who might have those diagnoses, that it would be a great idea for you to go and have a deeper conversation with your doc about getting you properly tested genetically for non-celiac gluten sensitivity, not the celiac gene test, because these are, again, non-celiac genes that play a role in the development of these other forms of autoimmune disease that often get swept under the rug, and people get put on immunosuppressants and very powerful medications that don't have great outcomes.
Yeah, and just to be precise and connect that research in a real accurate manner as best we can, you sent a lot of good studies supporting those things that you just said, that there's many conditions that have been associated with gluten in those that don't have celiac disease. And I did read through those ones you just sent. That's where I came to the discussion about the Salerno criteria. Is by and large, they were referring to non-celiac gluten sensitivity as defined by Salerno criteria. They didn't talk about currently being recognition for genetic tests being predictive for that, but they do have some gold standard ways of diagnosing that. So if someone is concerned, there are ways that can be sorted out.
Absolutely, and I'll point this out. I use genetic testing clinically as a gold standard in the presence of autoimmune types of conditions in my clinic, as a measure to help people decide how to change their diet. Not everybody follows that line of thought, and I'll be very clear on that. What's interesting on that note is that Mayo Clinic actually is now using Hla Dq testing, not for every condition associated with non-celiac gluten sensitivity, but specifically for IBS, not inflammatory bowel syndrome, but in irritable bowel syndrome. They're now using that as a gold standard in their kind of in their diagnostic flow chart that if somebody has a negative biopsy and persistent IBS, they actually use Hla Dq genotyping now to isolate those people who could go gluten-free to recover from irritable bowel syndrome. So
that's great.
There's precedence in my clinic, but there's now becoming precedence in other areas, in other diseases as well.
And any closing statements about, I don't know, other cases you've had, or just other perspectives for people about trying to correct their health? Or
I think if you're out there really looking to correct yourself, the number one thing that you should really focus in on is paying attention to how your body moves through the world, like paying attention to how you respond to activity, to exercise, how you respond to food, like just being self-observant. Puts you in a greater level of control, because sometimes advice coming from doctors, as well-intentioned as it might be, could be the worst advice. I've seen cases where people were told to eat whole grain, for example, and every time they did, their arthritis would flare, but they ate it anyway because their doctor said to. And so they ignored their own symptoms and their own experience because they wanted to follow their doctor's orders. And I would say, doesn't matter who your doctor is. Even if it were me, if I told you to do something and you felt worse doing it, that shouldn't be a cue in for you to keep doing it. It should be a cue in for you to have a deeper conversation with the doctor. So self-observation being very important. And then beyond that, I would say, you really start with the fundamental of eating real food and really helping identify what food is. And so when we look at a lot of the foods that people eat today, they're highly processed and highly contaminated with a number of different chemicals, yet we still call it food. And I would argue that should actually change. We should call real food what it is, and we should call processed food what it is. And I think a lot of people would find improvements in their health just by making that simple change.
And I just love to hear a bit from your clinical experience too, just to inspire people. You've seen lots of cases to where people thought that their situation was irreversible, they couldn't change that, and yet following some of these guidelines, it could. Any just closing statements along those lines?
I would just, if you're really wanting to see the power of diet change and what I've been able to help people do, actually I have a collection, Alan, of some of the most powerful stories online that we've just kind of curated over the years. And if a person wants to visit our YouTube channel, it's Glutenology is our handle on YouTube. But there's a playlist in our channel called Success Stories. And these are real life stories. These are real life transformations of people from every aspect and every angle of autoimmune disease, from people who had terminal diagnoses to people who were not terminal but very sick, and people who were just kind of sick, and still, all walks of life, male, female, children, adults, that found changes in diet and nutrition and exercise and behavior were their answers. And so if you want to get encouragement, I would just encourage your audience to check those out.
That's awesome. We will get those in the show notes for sure. So Peter, it's been great to catch up with you a little bit. Appreciate your time. See you in a few weeks in August, I guess.
Yeah, I'll see you in August for sure.
That's cool. Hope you have an awesome summer and take great care.
Thanks, Alan.
And listeners, thanks for tuning in, and back with you real soon for another episode. Bye-bye. Hey, Dr. Christensen here. Thanks so much for joining me for another episode. Is there a topic you'd like me to cover? I'd love to hear from you. Just go to Dr. Alan Christensen on Facebook or Instagram, write your question, and use the hashtag #MedicalMyths. Did you find this show helpful? If so, please take a minute and leave us a rating on iTunes so that others can know. Thanks much, and I'll be back with you real soon. Bye-bye.